يعطيك العافية. السلام عليكم ورحمة الله. First of all, thank you to the organizing committee, to Dr. Wiam, for inviting me this year as well to present. Um, I'll present over the next few minutes our most recent work that we've done on PCOS here in the Gulf region, with a few updates on the guidelines as well. So to begin with, a reminder, I think, for all of us, PCOS is a very complex disorder. It's not just an endocrine disorder or a reproductive disorder. It's a combination of metabolic issues, hormonal issues, psychological issues, etc. And we don't really know where the origins of PCOS, or where does it start. Does it start at the level of the ovaries with high levels of testosterone? Does it start at the level of the pituitary with high levels of LH? Or does it even start at the peripheral sites at the level of insulin receptors, whether it's in the fat tissue, the liver tissue, etc.? But what we do know is that there's a complex interplay between all of these different components, and that gives us the polycystic ovarian syndrome picture. Now, polycystic ovary, I always tell my patient, is a very misleading terminology, because often we do have PCOS ladies who have absolutely no cysts on their ovary, and vice versa. We have females with polycystic appearing ovaries, but at the present time, you cannot make a diagnosis of PCOS based on their symptomatology. And so really it's a metabolic reproductive disorder rather than a polycystic ovarian syndrome disorder, but the name is quite difficult to change, and I think it's here to stay. Why do we really care about PCOS? We care about it because, at least in the endocrine specialty, because it's really one of the most common endocrine disorders that we diagnose in the reproductive age. This is a population-based prevalence of PCOS, again, based on the Rotterdam criteria that we'll go over in a second. And it basically shows that the prevalence can range from 15% up to even 20% in certain populations. So it is quite prevalent when you have 1 in 5 females of reproductive age suffering from a disorder. This is a study that we did at the Department of Medicine at RCSI, where we surveyed over 12,000 female subjects within the Middle East region, particularly though, or most of them were focused in the Gulf region. And what we did ask these patients is to self-report whether they had PCOS, thyroid, prolactin, etc. And what we saw was about 1 in 3 females within the reproductive age had actually a PCOS, or at least self-reported a PCOS diagnosis, which was double that of thyroid and probably 4 times the prolactin issue. So it is really quite a very common endocrine disorder that is very much underappreciated, underdiagnosed, and undertreated in our part of the world. So how do we make a diagnosis of PCOS? There are a lot of criteria out there. Probably the most used one is the Rotterdam criteria, and it hasn't really changed. So what you need is 2 out of 3 to satisfy a PCOS diagnosis, and we'll go over each one of them. But the first thing, and probably the foremost important thing, is to make sure you exclude other causes of amenorrhea, oligomenorrhea, etc. So you have to test thyroid, you have to test prolactin, in some situations 17-hydroxyprogesterone for the congenital adrenal issues, and then sometimes also DHEAS if you're suspecting adrenal virilizing tumors. So essentially PCOS is really a diagnosis of exclusion. And for me, the word diagnosis of exclusion really undermines the magnitude of PCOS as a diagnosis and as a disorder that a lot of females suffer from. So in essence, you need 2 out of 3 criteria to satisfy that PCOS. So the first thing is illegal ovulation or anovulation, normal periods being from 21 to 35 days, so anything above or below that. Or if you have amenorrhea, where you're skipping periods in the case of irregular cycles for over 6 months, then you do satisfy criteria 1. Second is either clinical or biochemical signs of hyperandrogenism, and this is very important, and I'll I'll shed some light onto the research that we did in this particular area. And then lastly, our polycystic appearing ovaries on ultrasound. And of course, that by itself, there's a specific criteria as far as number of follicles and size of ovaries. So if we wanted to look at two of these criteria, the legal ovulation and clinical or biochemical signs of hyperandrogenism and the prevalence of those in our region, in the Gulf region, in PCOS subjects, the 3,300 PCOS subjects that we had surveyed, more than half complained or at least self-reported irregular periods. About 70%, this is astonishing. So more than half, close to 3/4 had the issue of hirsutism. About a half suffered from acne, and about 60% suffered from androgenic hair loss. The last three all being clinical signs of hyperandrogenism. The striking thing though is that the non-PCOS subjects in our 8,000 non-PCOS diagnosed subjects, they also had quite a high prevalence of irregular periods. About a third complained of hirsutism, 36% with acne, and 37%. So despite the fact that significantly, of course, more symptomatology was found in PCOS subjects, these high numbers just point to the fact that probably a PCOS, or making the diagnosis or the diagnosed cases of PCOS, we're just witnessing the tip of the iceberg. And there are so many other cases undiagnosed or underdiagnosed. So to focus a little bit on this hirsutism issue, we did some work. So hirsutism, of course, in PCOS subjects, how do you make a diagnosis, or what defines hirsutism in general? We use the Fairman-Galloway score. That's a pre-established score where we look at different body areas and you essentially assess the frequency or the abundance of terminal hair growth. So that's your male pattern or male level type of hair growth within the upper lip region, the chin region, and all of these other regions, and you give yourself a score, or you give the patient a score, and essentially you add those up. Either you get a 0 for absolutely no terminal hair growth, up to 4 if it really looks like a male pattern type of hair growth. And what's been established in the literature is that the Fairman-Galloway score has to be 8 or above for you to make a diagnosis of clinical hirsutism to satisfy the second criteria for PCOS. But what we do know is the Fairman-Galloway score really differs as far as threshold to make a diagnosis of clinical hirsutism across different regions. We cannot use the same score for people, for example, in Finland, and then apply it to those in India. And so this nice study from 2017 very nicely demonstrates that the Fairman-Galloway score differs in terms of mean across the different regions. And for patients who have established diagnosis of PCOS, we see that the Fairman-Galloway score mean of 15 in India for those with PCOS versus only 4 for those patients in Norway. So what about our Gulf region? What is our cutoff for the Fairman-Galloway score? So that's what we did. So this is the results of essentially surveying over 600 PCOS subjects and essentially asking them to grade the level of hirsutism in every one of the areas of the Fairman-Galloway score. And what we found was our mean Fairman-Galloway score for PCOS subjects in our Gulf region was actually close to the one in India, so it's about 14. And these are the different means of the Fairman-Galloway score across the different areas. And what you can see is that the areas with the most amount of hirsutism reported in our region is the lower abdomen compared to the lowest one, which is the upper back. This is also another striking finding that we've identified when we ask patients what treatments they've used for hirsutism, PCOS patients. What we saw was that the majority of the treatments for hirsutism used was essentially cosmetic, so it was really tackling the issue at its surface. When we do know that in patients with hyperandrogenism causing hirsutism, the problem really has to be targeted at the core. You have to really treat the roots of the problem rather than just cosmetically treating the surface. So about a third just reported using basic home treatments, shaving, etc. And then about a quarter used the beauty or the health center treatments like laser. Only 6.9% reported actually going to a physician to seek treatment, medical treatment for hirsutism. Then we were also interested with the psychiatry group at RCSI to look at body image satisfaction in those patients with PCOS suffering from all these different issues. Now we know PCOS is a big problem as far as physical appearance for a female. It causes all of this acne, the hirsutism, the baldness or the androgenic hair loss, besides of course the obesity issue, the hyperpigmentation from acanthosis nigricans, and all of those problems associated with it. And so it does have really a huge psychological impact on females. And so we looked essentially at the level of body image satisfaction amongst those with PCOS. And we really looked at whether hirsutism influences the body self-satisfaction. And what we did find was that, yes, absolutely, the higher your Fermi-Galloway score, the higher your risk for lower body image satisfaction. And it wasn't just the hirsutism issue that affected dissatisfaction with body image. It was actually a lot of the other symptoms in those patients with PCOS. So hair loss was associated with significant dissatisfaction, acne, acanthosis nigricans, etc. But I think the more striking thing that we've identified here is that even when non-PCOS patients have hirsutism, non-PCOS patients have these symptoms, still PCOS subjects with the same symptoms will report more dissatisfaction. So maybe it does point to some underlying psychological issues going on with patients in PCOS related maybe to mental health, genetic issues that predispose them to higher rates of psychiatric disorders or dissatisfaction in general. This is another look at different body image measures, not just a dissatisfaction with body image, but asking them about things like feeling attractive. Do I feel attractive? Do I avoid social interactions because of the way I look? Am I satisfied and confident? And throughout all of this, PCOS subjects reported less satisfaction across all measures compared to those with non-PCOS. Then the question becomes, is it really weight related? We do know from our study that the mean BMI for our PCOS subjects was 28, so they're already in the higher end of being overweight compared to non-PCOS, though they're still in the overweight category, which really tells us about the BMIs of this region and really where we're heading as far as weight in the next few years. Also, despite the fact that, and so it's not just higher BMI, but it's also the body shape is significantly more patients with PCOS had the rounded body shape, so the central obesity, which is definitely attributable to maybe a lower level of attractiveness for females compared to all the other types of body shapes. Also significantly higher levels of obesity, about a third. So was it weight related, the lower levels of body image satisfaction? And the answer is no, not quite, because even when you look at the underweight PCOS subjects versus non-PCOS and the normal weight PCOS subjects versus non-PCOS, we did see in our study that even when you're in normal weight or underweight category, PCOS subjects again had higher rates of dissatisfaction compared to non-PCOS subjects. And that difference probably magnifies even more when you are obese compared to being underweight or normal weight. Briefly, a little bit about PCOS therapies. I'm going to review with you the latest, though they're not very late, the 2023 International Evidence-Based Guideline for the Assessment and Management of PCO. I won't go over all of them, but I did highlight a few things that sort of stood out for me in the evidence-based guidelines that I do still see in practice, but probably need to change in the next few years. The first thing that they emphasized was that Diane, or the brand, the generic 35 micrograms of ethanol lansoprazole, estradiol with cyproterenone really should be considered a second-line therapy compared to all your other OCPs, particularly because of its high risk of venous thromboembolic risk. So less in favor of using this type of OCP compared to all the other types of OCP. The second thing that also they highlight, and this is often that, what I see, patients coming from other specialties, particularly primary care, being diagnosed with PCOS and being put immediately on metformin. Really, metformin should only be considered if the BMI is over 25. So you're in the overweight versus obese category as opposed to normal weight. So if you're really a thin PCOS subject, are you really benefiting from metformin or not? Again, limited evidence for using PCOS alone in those with lower BMIs. OCPs, of course, should always be used over metformin when you're treating hirsutism or irregular menstrual cycles. Metformin has limited use for hirsutism. And metformin can be used, of course, over OCPs, again, for the metabolic indication. I think this is straightforward. This is a new addition. Anti-obesity medications, particularly your GLP-1s, should be considered along, of course, with lifestyle interventions to manage adults with PCOS who are in the higher weight category. Of course, you have to use effective contraception when using the GLP-1 receptor analogs, as they're contraindicated in pregnancy. And of course, the biggest issue with GLP-1s I think we're all facing is the weight regain post discontinuation. And so you really might need to consider long-term use of GLP-1 receptor agonists because of that risk of weight regain and sort of counteracting all those benefits that you have acquired from the use of these injectables. And then as far as supplements, which is really, not much talked about in the medical world, but heavily discussed always in clinics by patients who want natural alternatives. And hence, you see the social media always packed with the natural type of alternatives. They do mention inositol, which I have used in clinic in specific formulations, Mayo plus Dinositol in particularly 40-1 ratio. It can be helpful for those with mild menstrual irregularity to help regulate things a little bit. But again, the clinical benefits are a little bit limited as far as ovulation hirsutism, and definitely not that effective for weight loss. That should be it, brief and hopeful.